I think one thing that we've seen, and I've reviewed all the posters and the presentations so far, is that I think there's a general trend over the last few years for real data on the studies. I think the quality of the posters and the presentations have increased. I think people are really making a great effort to do clinical trials in older patients and, again, present their data. The data includes a lot of patients, reasonable numbers, reasonable endpoints, and is making valid conclusions about their studies. I think it's contributed to the field itself and, of course, to the quality of the meeting. The other good thing is that this year's SIOG meeting has the largest attendance ever. We have over 500 registrants. We've never had that number before. And I think that bodes well for the society and for next year's meeting. So far, I think it's been very good. I think it's been well organized, and I think the responses so far have been very positive. We've had, I think the latest number is 36 guidelines published, 9 this year. I think they're making a lot of incremental changes to improve quality of life and other aspects of treatment. I think people are getting, we've spent many years doing predictive models of geriatric assessment, predicting toxicity, predicting decline. And I think what this phase of geriatric oncology is doing is incorporating these predictive models into studies, and by doing that, it further refines the model and enhances outcomes. And I think that's reflected in the talks and the poster presentations. I think, a lot of times these changes are not huge leaps, but I think when you look back over the last decade or so, you could clearly see these incremental changes year after year, and I think part of that is the fact that we just entered this new era of implementation of the results that we had from previous years. Well, I think it changes because a number of things change. The drugs change. We spent decades worrying about chemotherapy side effects, and we've really entered strongly, we talked about it's going to happen, but it really is happening, an era of immunotherapy, targeted therapy, genomic-based treatments. And so the future is where the therapy leads us. I think if you have drugs with a higher therapeutic index, where the concern about toxicity is less, then you evaluate the patient in a different kind of way. If you're not worried as much about toxicity, or at least you feel the toxicity is manageable, then the way you make a decision changes. So I think the future of geriatric oncology, from a decision-making point of view, will be dictated to a large extent by what therapeutic modalities we have. Obviously, the predictions of an aging population are true, and so I think people who are interested in geriatric oncology have a lot of work ahead of them, and there'll be a lot of patients to take care of. And there'll be new avenues of approach. And I think as in an aging population, and hopefully with less comorbidity, things like surgery will have a different approach. Surgical care will be, I think, improved because of that. Maybe less surgery in some circumstances. Radiation therapy may change, limited. We see that now with more tumor-specific radiation therapy or other modalities yet to be determined. So I think a lot will it'll go where the therapeutics take us.